So let me begin by introducing my ex-partner. And I don't have a real ex, but Buck Davies and I were in business 20 years ago for about 10 years, McFarland Davies Architects. He's here today, and I'm so thrilled. He's also the architect of this building, the last expansion. So please don't tell him bad things, only good things about how great the building works. And he's also Jabraan's father-in-law. Anna, he's Jabraan, our speaker's father-in-law. Anna Davies, who's one of my dearest, youngest architect friends in the world, is married to Jabraan. And so I've been trying to get Buck to come to Sunday school for a long time, and I finally got the trick, which is having Jabraan speak. So let me tell you about Jabraan. You've probably seen Jabraan. He's been here twice, I think it's 3 years ago. But Jabraan is a graduate of Booker T. Let's see, Mark, all the Hornets. He went to KU, has his first degree from there, his medical degree from there. He went to Arizona to study at Mayo to become an internal medicine physician. He worked at Ascension Health. When my brother had his heart thing, Jabraan was all over him, hospitality and healthcare and everything you could ever do. One of the best, worst health experiences ever, but he had a great positive outcome. And that's kind of the key word, I think, when I think of Jabraan. And I think Jabraan will agree, it's positive outcome. And Jabraan kind of went more into public health than really being a doctor. Although when I did look you up this morning on Google, it says you have a practice 3.5 miles from my house. So be careful. I may be coming because my internal medicine guy just retired, as you know. But anyway, Jabraan's specialty right now is kind of getting more into community public health, which is where he's kind of been all along. He has made over 250 presentations around the world in his young life, talking about healthcare and health outcomes. And I try not to bother him because I'd have him come a lot. But when I saw his name in the paper 2 or 3 times that he was on Mayor Nichols' panel for improving the health outcomes of our city, I had to do it, had to bring him back. And I think you all are going to really enjoy hearing from Dr. Jabraan Pasha, who is currently the Director of Health and Well-Being for the City of Tulsa. Thank you, Jabraan.
Thank you. Good morning. Y'all hear me okay in the back? Great. Well, it's wonderful to be here. We were trying to figure out how long it's been, and Mr. Hames, who was my high school chemistry teacher, reminded me, I don't know where he's at. There he is. Reminded me that our daughter was just born when I was here the first time, and she's about to turn 4 in a couple of weeks. And so was hoping to bring her and Anna, but unfortunately she was up coughing all night. And so I can either say, and I didn't sleep much at all. So I can either say I can roll out of bed and do this, or I have an excuse. So whichever way it works, I'll lean into that. It's just good to be in front of such a warm and welcoming group. That's not always the case when you work in the mayor's office. So this is a nice Sunday morning to spend with you all. I'll give a little bit of context because, as a physician, there's a lot of ways that you can serve the community, and in the traditional sense, it is working in a doctor's office, seeing patients, which is noble and needed and necessary, right? And when I wanted to be a doctor, I knew when I was probably my daughter's age that I was going to be a doctor when I grew up, and I had this traditional sense of what a doctor was. And for me, it was an internal medicine doctor who would either work in the hospital or work in the clinic and see patients who were feeling sick and do whatever I could to make them well. And I did that for about 10 years, but I kind of found myself, Is it not working? Let me use this.
No, position.
Okay, thank you. All right. You think I'd figured this out by now. All right. Okay.
Grab it.
Here. How's that? Do it. How about we just use the handheld? Yeah. I said this was a welcoming group. That's right. Thank you. Is that better? Good. Test, 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 test. He's checking the volume. There we go. Thank you very much. All right. Okay, I'm gonna start over. No, I'm kidding. So I really had this idea of what a doctor was, and as I kind of got more and more into my career, there was a question that kind of kept me awake at night. We all have those questions that keep us awake at night, and for me, it was what shapes health, right? And another kind of component of that question was, why are certain communities less healthy than others? And that is really what that question has kind of driven my career in a few different directions, and has kind of led me in a path to, one, answer that question, and then two, find ways to make it so that it's not the case that certain communities are less healthy than others. And so, I worked at OU for quite a while, at St. John as a hospitalist, and then I joined a startup and opened a clinic in Greenwood. And then I had an opportunity, people call it like a transition. It's also unemployed is also like another way to refer to it. So I had a lot of time to think about what I wanted to do and how I was going to make my impact. And I had this idea that our city, or cities in general, should really have an office and a person within that office whose responsibility, whose primary goal is the health of the community. And ironically, that doesn't really exist in cities. There's the health department, which is different, has different goals, but really, from my research, there really weren't any cities in our country that had an office of health embedded in the mayor's office, or an individual whose role was to really steer the health of the city. And so I thought, there's clearly a reason why this doesn't happen, and we'll find out if this works or not. But I kind of had this idea and really wanted to pitch our mayor on this idea. And Mayor Nichols got elected in December, and we had a relationship previously. And so I said, great, I'm going to reach out to him and kind of pitch him on this idea. I did not want to call him on day 2 while he was in office. And so I told myself I would give him a couple of months to get his feet settled, and then reach out and say, hey, can we have a chat? It turns out he calls me 2 weeks into his term and says, Jabraan, have you ever thought about working in the mayor's office? And I said, actually, I have. And I'd love to talk to you more about it. And so we sat down first week of January, and it turns out that we had the same idea of what the city needed to address the health issues that we have. And so it really made me feel that this all kind of worked out the way that it was supposed to. We were both well aligned. And so here we are, and I'll kind of talk to you about what our plans are for the health of the city. And so there's really 2 questions that I have. One, I think, is a question that we can absolutely agree upon. There's no right answer, right? Reasonable people can disagree on the answer of this question here. And that question is, what role should a city play in the health of its citizens? I feel a certain way about that. I think traditionally and historically, the answer to this question has been, the city does not have an active role and should not have an active role in the health of the community. They create an infrastructure for the private sector or the public sector, but not the municipality, to create a healthier Tulsa, but they don't have their hands in it themselves. That's historically how cities have approached healthcare, right? They provide a canvas for healthcare to be delivered, I guess is a good way to say it. I don't think that's the approach. Because it is the city that creates the poor or the good health outcomes for the community. It's everything that a city does, right? And so I think the city should have a more active role in the health of the community, right? And really that word, adjective, should be proactive role. And I'll talk to you specifically about why I use that question, that term. The second question that I have, I've already kind of teed up, is a question that I can tell you for certain there is an answer to, a right answer to. and there's a wrong answer. And I think we've approached this question from the wrong perspective for a very long time. Okay? And I think if I were to ask you all to take a guess about how much money our country spends on healthcare in a year, you would probably miss it by an order of magnitude. You would probably miss it by a decimal point. All right. We spend $4 trillion per year on healthcare. And if you were to guess, where do you think that puts us in the rest versus the rest of the world? First, right? Which would be okay if that investment was resulting in better health, right? And there's about 11 kind of industrialized countries in the world. We spend more than all the other 10, and we have the worst health outcomes. All right. And so we have focused our resources really in the wrong place, and we're not getting that return on investment that we should, right? It's because we have had a poor understanding of what shapes health. We've emphasized the actual delivery of healthcare and medication and procedures and doctors and nurses and hospitals and facilities. That's where the resources have been placed, right? But we actually know, and this is hard to say as a physician. I know we've got Dr. Lynch, who's a physician. It's hard to say as a physician, but we know that the actual delivery of healthcare, the actual, receiving of healthcare only accounts for about 10% of an individual or community's overall health outcomes. 10%. Yet we spend almost all of our resources at the point of care. What actually makes the biggest impact on health outcomes? It's these things here. It's what we call the social determinants or social drivers of health, right? It's kind of where we live and play and work and worship. We know those contexts are actually what drives health. We know that there is no factor that impacts health outcomes more than how much money someone has. On average, the more money you have in your bank account, the more money you have access to, the healthier you are, right? And it's a direct linear correlation, meaning that if on that line you are middle class, socioeconomically speaking, you on average will have better health than someone who is lower middle class. And respectively, you on average will have lesser health than someone who is upper middle class. And that's pretty tight on that line. So imagine if we're looking at someone who is wealthy versus someone who lives in poverty, what that average gap to wealth is, right? And we see that not only in Tulsa, we see it everywhere, but in Tulsa specifically when University of Oklahoma School of Community Medicine did a project. Matter of fact, Connie and Buck were the architects to answer the call from what this research study showed. They showed that in a zip code in North Tulsa, predominantly black part of Tulsa, compared to a zip code in South Tulsa, predominantly white part of Tulsa, the life expectancy gap was 15 years. Meaning just by accident of birth, as I like to call it, you happen to be born and raised in North Tulsa, you were going to live till you were about 65 years old. If you were by accident of birth, born and raised in South Tulsa, you were going to live till you were about 80. Tulsa's not unique. We see even bigger gaps across the country. And so a lot of that has to do with wealth gap, right? And to address the healthcare shortage in that part of town, Wayman Tisdale Clinic was built in North Tulsa, literally by Connie and Buck, which is a cool story. We also know that education plays a big role in our health outcomes, and it's not as linear as income because there's a threshold. And so we know that if you can achieve a college degree, you can kind of squeeze every ounce of health that comes with an education. So if you can get to that level of a college degree, then you get the health benefits of being educated. And we're not talking about health literacy or health education, just education in general, right? And so education plays a big role. We know that just having access to quality health care plays a big role in our health outcomes. And one thing I'll say, and I've done a lot of time going from institution to institution and organization to organization since I've been in this job for the last 7 months. Tulsa has a lot of healthcare. Like, let's be clear, there is a lot of healthcare in Tulsa. We've got 3 large health systems, right? One of which in St. Francis is the 11th largest hospital in the country. It's the largest employer in Tulsa with 12,000 employees. Like, we've got healthcare. We've got all these insurers. We've got 2.5 federally qualified health organizations. We've got countless, public and community health organizations. What we don't have is great access for everyone. And so there's a relative shortage for some people because not everyone can access the services that are available in Tulsa. And so we know that having poor access to healthcare can impact health outcomes as well. The neighborhood you live may be the biggest factor in shaping your health outcome. And so we call this the neighborhood or the built environment. And that encompasses things like what you have access to in that neighborhood, food, right? Clean air, sidewalks for physical activity, green spaces, right? Resources, all of those things impact our health as well. And then something we call social and community context, that is really talking about the impact of bias in healthcare. And we know that the bias on behalf that comes from healthcare workers like myself impacts certain groups more than others, right? And so you put all this together, these things actually impact health more than the actual delivery of healthcare, right? And so there really needs to be a fundamental shift of where we put our resources, and we have to stop thinking of health as the absence of disease. Does that make sense? It's a continuum, right? So we know that before you get sick, you have to do things and have access to things and take steps to set yourself up to be healthy, right? Just because you don't have a disease does not mean you're living a healthy lifestyle. And you have to live in a neighborhood or a community that can provide all that you need for that healthy lifestyle. I think one of the best analogies that I can't remember if this is my analogy. I probably stole it. But it makes a lot of sense. It's that when we have a headache, we'll take, say, Tylenol, and that headache will go away, right? Although Tylenol can fix our headache, it does not mean that our headache was caused by the lack of Tylenol, right? So if you put that in the healthcare perspective, if you're sick, you get healthcare, you get better. That doesn't mean that our sickness was caused by the lack of healthcare, right? So our answer has always been more healthcare, more healthcare, more healthcare. That's the wrong approach, right? And since you all brought up Tylenol, Tylenol does not cause autism. I'll put a period on that. So what works out really well is that all the things that I know from all the research that's been done over the years that actually impact health align amazingly with the mayor's priorities, right? And this is not by chance. It's because he recognized before I was even involved, I had nothing to do with these priorities. He recognized that all of these things, most of these things on this priority list actually result in better well-being, right? And so we know that if someone does not have access to quality housing, that is going to impact health. We know if someone does not have an opportunity to be successful in school, our children don't have access to a great education, that's going to impact health. We know that if there is public safety issues, that is going to impact health. We know that if there's not economic equality, that is going to impact health, right? So while these are mayoral priorities, these are also health priorities, and we are going to incorporate these into our outcomes for the health of Tulsa. That's all good, no problem. So, okay. So a few weeks ago, maybe a month ago now, we had a big press conference at the city to announce the Office of Health and Wellbeing. The first of its kind at the city. We can't really find any other cities that are doing anything similar. We had some amazing strategic partners in community care and George Kaiser Family Foundation who stepped up with some infusion of a great amount of money to kind of help us start to kind of lead and kind of activate some of the things that we want to do. This is going to be, I think, a really wonderful opportunity. The big challenge that I have is while there's so much healthcare in Tulsa, most of it kind of operates in silos. There is not a great deal of collaboration or partnering amongst the kind of the healthcare stakeholders in town. And you can understand there are, competitors in the market and, there's kind of always this thought of there's a zero sum game. There's only so many patients to go around, and it kind of creates this competitive, agenda for some of our healthcare players. That has to go away. There are plenty of patients to go around. There's plenty of need to go around. And so my challenge, probably because no one else was willing to try to tackle it, is that we've got to get all of these folks to the table and start to work together. What makes me hopeful is that when we held the press conference, Buck was there, they said it was the most well-attended press conference that the city has ever held. There was nowhere to sit. And we had leaders from literally every healthcare organization in town that were in that building. And it's not because of me. It's because they understand that if we're going to do better, we have to find ways to work together. I mean, if you can get St. Francis and Hillcrest and St. John to sit next to each other, if you can get OU and OSU to sit next to each other, if you can get Morton and Crossover to sit next to each other, that's actually a really big step. And so the fact that people showed up says that they believe in what we're trying to do, and makes me excited about partnering. So let's talk about the actual work that we're going to do. One of the first things is leveraging that idea that we have to start to work better together. And so we're going to stand up what we're calling the Mayor's Health Coalition. And we're going to have leadership from all of the healthcare organizations in town, from Community Care, St. Francis, Hillcrest, to the smaller community organizations that really are the heart of health in this community. There are so many smaller organizations that do impactful work who have, I think, more of an ear to what the community needs. And so we need their voice at the table as well. And also community members, right? It doesn't make sense to stand up this coalition with all of these big dogs, who make all of these decisions and not have the people who are going to be impacted by those decisions the most at the table. And so it's important for me to also have space for the community and people who are receiving the care from all these organizations to have a voice in what we're trying to do, right? And so this coalition is really going to provide an opportunity for us to find kind of low-hanging fruits of opportunity, find ways to share resources, find ways to share insights, and do it in a collective and collaborative way. I think that is maybe going to be the most important thing that we do out of this office, because if we can get everybody moving in the same direction, we can really make some big strides in this. And so the mayor is committed to being at every one of these convenings that we have, and I think that's going to go a long way of kind of setting the tone that this is something that the city cares about. So we're excited. We'll have our first one in mid-November, and we'll kind of be generating reports from what we've learned and goals and follow-ups from those meetings. One of the, I think, most incredible tools that the city has access to is something called the Neighborhood Conditions Index. And this was developed by the City Planning Office, actually. And the mind behind this tool actually is a woman named Paulina Beza, who's an architect trained in Mexico City. She then went to OU Tulsa's urban design studio and trained under Sean Schaefer there, and then took a job at the city as one of the head planners. And what they did is they took City of Tulsa and they divided the city up into 80 individual neighborhoods. You can see them all here. And the groupings are kind of all alike. So if you are within one neighborhood, the demographics, the resources of that neighborhood are more or less very similar, right? So you have 80 individual neighborhoods. And then with this tool, what they did was build in all of this mainly publicly available data, census data and some other data, some private data. And it allows us to select any neighborhood, right? And learn who that neighborhood is. So we can get population, we can get racial and ethnic breakdown, we can get workforce data, we can learn about their income. And then I think the most amazing part of this tool is that you can click on a neighborhood and you get all this social drivers data. For example, you can click on a neighborhood and see what's the distance to healthcare in that neighborhood. You can click on a neighborhood and say, hey, what's the distance to parks and green spaces? What's the distance to healthy and fresh foods in that neighborhood? What's the percentage of health insurance coverage for this specific neighborhood? And so they took these 52 data points that you can get in any of our neighborhoods, and then it allowed us to compare the resources available from neighborhood to neighborhood. That's the index part. And each neighborhood then gets a priority score. So priority score 1 are neighborhoods that have a lot of opportunity, meaning that there are a lot of needs that are unmet in those neighborhoods. Priority group 2 is the neighborhoods that are kind of in the middle. Priority group 3 are the neighborhoods that really have access to the most resources in our city, right? And so as we're trying to plan out where our resources should go, we shouldn't send a lot of resources to our priority group 3 neighborhoods because they're doing so much better than our priority group 1 neighborhoods. And so one thing that we've done with this is we've created this pilot. So Mayor Nichols signed an executive order creating this neighborhood conditions index pilot. And they let all 80 neighborhoods, representatives from all 80 neighborhoods apply to be a part of this pilot program. And they selected 3. They selected Sequoia neighborhood, Charles Page neighborhood, which is in West Tulsa. Sequoia is kind of northeast Tulsa, and then Suburban Hills, which is in north Tulsa. Those were the 3 neighborhoods that they selected. And they had representatives for these neighborhoods. They met with them every other week and went over their score from the neighborhood condition index. So each neighborhood learned what they're doing well, what they're not doing so well in. And then they sat down with them and said, hey, what are your priorities? Like, what do you want for your neighborhood to thrive? What rank the needs of your neighborhood? Almost every one of those neighborhoods said walkability, right? And public safety was another one. And then just cleaning the neighborhood up. It was kind of a code enforcement thing. And so what they did is they sat down with these neighbors from each of these neighborhoods and said, okay, you want your neighborhood to be more walkable. Let's talk about what that looks like. So that maybe looks like more sidewalks, right? Better signage, right? Taking care of loose animals, right? That was actually one of the biggest factors for why people don't walk their community, because there's loose dogs and it's unsafe. And we didn't really think about that, but that came up time and time again, right? Which is a relatively fixable problem, just like putting more sidewalks, right? And so they sat down with these community members, and we had people from the planning office and public safety and streets and parks at these meetings. And then they created a plan, and they said, hey, if we want to make this more walkable, we need to, fix this number of feet of sidewalks and put up this number of street lights. We need to deploy more animal services or more police officers. And then each neighborhood got $1 million to $1.5 million to actually make those improvements in their neighborhood. And so these community members are deciding what the problems are. They're deciding what needs to be fixed. They're working with the city to figure out how it needs to be fixed. And then the city is supporting the kind of beautification, and improved safety of these neighborhoods. And so that's putting this neighborhood conditions index tool to work. And we're hoping that we can do this for more neighborhoods across the city next year. And what I'm going to do and what I want to do, when I learned about this tool, I said, this is incredible. And everybody that I told about it was kind of blown away by the opportunities that were there. We're going to work with the planning office to build more health data onto this tool, right? Aspirationally, I want to be able to click on this and say, hey, what's the rate of heart disease in this neighborhood? Or what's the rate of teen pregnancy in this neighborhood? Or what's the rate of prenatal care in this neighborhood? So then we can kind of target our initiatives based on what the data is actually showing on this tool. And no other city has anything like that. And we're hopeful that we can pull it off. It's going to be tricky. It's going to cost some money. We're going to have to access the right data. But there's enough people in the community that are excited about the possibility. I think we can get there. So let's take a little snapshot of some of the data that we were able to pull from this neighborhood's condition index. And I want to do just a little bit of an exercise. I always do this when I get in front of a group, because sometimes sometimes it's exhausting to be empathetic to other folks' situations, right? It does take a certain degree of empathy to care for communities that are less fortunate than our own, right? And what I found is like part of my job, but even I run low on empathy at times, right? And so what I try to do to kind of fill my empathy tank when it runs low is just take a minute to reflect on the privileges that I've had in my 41 years of life. Because there have been barriers that I just haven't had to overcome. And that has helped propel me and provide some success, right? It doesn't mean I didn't work hard. It doesn't mean I was undeserving. But it means there were times where I had some privilege that opened doors for me, right? And that starts early, right? I grew up with a 2-parent home with parents who were loving and told me so and provided. And we maybe didn't have a lot of money, but the lights were always on. The food was always on the table, right? There's no domestic violence in our home. It was a stable, warm upbringing. And that is a privilege, right? I've had access to good schools, public schools, private schools when it made sense, but mainly public schools. That's a privilege. Now I live in a neighborhood that has a Trader Joe's, a Whole Foods, a Reese's, right? A Walmart neighborhood market all within about a mile. That's a privilege, right? And so I reflect on that, and that helps me just reset and realize like there are a lot of folks that are less fortunate than I am. And it allows me to kind of fight and advocate for the folks that didn't have the privileges that I've had, right? And so as I say that, let's talk about some of these gaps in privilege across Tulsa neighborhoods, right? And I picked kind of 2 glaring examples, right? It may be for reaction, but this is real, right? People live, grow, and play and worship in both of these communities, right? And so what I want, as I kind of go through this, I want you to think about how living and growing up in these 2 different neighborhoods could make it easier or more difficult to be healthy, right? So let's take Maple Ridge, which has, I think, the highest median household income in Tulsa. One of them, if Maple Ridge or a couple other neighborhoods are right on the cusp there, right? So Maple Ridge, Midtown Tulsa, median household income is $125,000 compared to Hawthorne, a neighborhood in North Tulsa, right at 36th Street North in Peoria, kind of in that corridor. Median household income of $27,000. What is that? 5 times difference, right? 20% of Maple Ridge. All right. So as we have learned that income can impact health, that is a very glaring example, right? And think about how priorities change between these neighborhoods, right? And even on like things we take for granted, right? You walk by and you see sprinkler systems, watering the lawns and flowers and like kind of extras that you would call, right? In a neighborhood like Maple Ridge, right? And you go to Hawthorne, you don't really see that because there isn't that disposable income, right? The priorities are different. It's either water the lawn maybe or keep the water on, right? So you can think about how priorities may differ just because of this wage gap, this financial gap between these two neighborhoods. Transportation is something that is a big factor and it contributes to health. You can't get to your doctor's appointments or you can't get to a grocery store. You're forced to get what's in your neighborhood, which may be fast food or dollar stores that don't have a lot of healthier options, right? I think it's fascinating that the differences in just having access to a vehicle, right? So 60% of folks in Maple Ridge have 2 or more vehicles in their family. That's only 28% in Hawthorne. Education, we talked about it, right? Getting that college degree is critical for a lot of things, health being one of those. And almost half of the folks who are of age in Maple Ridge have a college degree, just a little bit below 12% in Hawthorne. Again, think about how these are starting to adjust that life expectancy difference, right? As these things start to add up, right? Home ownership, probably one of the single most effective ways to grow wealth, right? Through equity, right? And if you don't have opportunity to own your own home, you lose on that and you're paying rent and that money goes away, right? You don't build equity from that. And so in Maple Ridge, 70% of the folks who live in that neighborhood own the homes that they live in, 43% in Hawthorne. And that doesn't tell the whole story, right? Because homes in Hawthorne are not growing in value the way that the homes in Maple Ridge might be, right? And then businesses, right? One of the ways that we build funding for our public schools are through sales tax, right? And so in Maple Ridge, where there's 303 businesses in that neighborhood that are generating sales tax revenue that are being applied to a lot of things, one of those being the public schools in that community. You can see how they're building more robust, effective public schools, whereas there's only 53 businesses that are identified in the Hawthorne neighborhood. And so that sales tax revenue is quite smaller, which means those public schools in that community are not getting the funding, right? So as we take a step back and think of this from a big picture, there's no big surprise that the life expectancy and the health differences exist in the way they do across not only the Tulsa community, but any community. And we can exchange these names if we're in any city and find very similar examples, right, of neighborhoods that are thriving in Maple Ridge versus neighborhoods that may not be thriving in the way that we would hope for them in Hawthorne. Does that make sense? Do you guys kind of start to see the way we are looking at health that's a little bit different than we just need more clinics or we just need more doctors? Because it's the neighborhood that makes us healthy or makes us sick. There's actually a book called Our Neighborhoods Are Making Us Sick, right? It's because those are really the basis for our health as we grow up and live in those neighborhoods. So initiatives. So one thing I'll say, and I think people maybe felt like I was a bit elusive early on when I tell them about what we're trying to do. And they're like, okay, well, what are you going to do? And I would always say, well, I don't think it should be decided by me solely, right? It shouldn't, right? It should be decided by the healthcare stakeholders, right? Which are the folks that we're going to convene in this Mayor's Health Coalition, because they live it every day and they have insights that I don't. And there's kind of a wisdom of the crowd in that when you are able to pull everyone together. And so a lot of our initiatives are going to be informed by that group, which does include community members, right? And then maybe more than anything else, it should be informed by the data and the research. And so that's what's going to come out of the Neighborhood Conditions Index. As we start to layer in data into that tool, we'll start to have some insights about where we're doing well, where we have some opportunity, and we will kind of design our initiatives off of that. But there are some things that I know we're going to do, and I'll talk about that now. And one of those is around mental health. We are in a mental health crisis right now. Oftentimes when we think about mental health crisis, we think about severe mental illness like schizophrenia and bipolar and those sorts of crises. But just the general public is in a mental health crisis. There's lots of depression. There's lots of substance use. And now is not the time to pull away those critical resources. And that's what we're facing right now. Where we have this wonderful resource called COPES that initiates when someone calls 911 with some sort of mental health crisis. And it's wonderful because it recognizes this is not a person that needs a police officer to be pulled away from true public safety to go to their home. This is not a person that needs a firefighter to be pulled away from public safety. This is not a person who needs EMS to be pulled away from public safety to go to them home. This is someone who needs a mental health professional. And so there are channels in place that when they get that call, they ask these questions, they're able to identify, actually, this person needs mental health services, and they send or get them in contact with a mental health service provider, freeing up our police to do police work, our fire to do fire work, and our EMS to do EMS work. All right. And to date, in not even a year, I think it's been 10 months, we have diverted 3,500 police, fire, and EMS calls to mental health services. All right. Think about the money that saves. Think about the services it provides for people who need it, who don't need to be in hospitals. They definitely don't need to be in jails. They need to be in front of a counselor or a psychiatrist, right? Well, with the recent cuts that got announced last week, funding for COPES was yanked, all right? And so we've got to talk to our Congress folks and our representatives and stand up, because it's working, right? We have a very innovative, it's called alternative response program built into our city, where we allow our public safety officers to do the work that they need to do and not have to be pretending to be mental health providers when they don't have the training or the time or the resources, right? And so, we are working on kind of making the case, and the mayor is making statements and pulling together meetings, because we have to find ways to replace or save this funding, because mental health is going to be one of the big initiatives that we have. Also along that mental health spectrum, we have a $4 million federal children's mental health grant that's now in year 3 of 4. So we've got 2 more years to run that grant. It's going really well. It's providing really critical mental health services for our youth. As we think about the mayoral priorities of student outcomes, if they aren't mentally well, they are not going to have good student outcomes, right? And so this feeds right back into them, and getting our youth that have significant mental health struggles as well the help, the treatment they need so they can perform well in school is going to be critical. And that grant allows us to partner across the city with the folks that are doing that work. We're kind of quarterbacking that, but we're addressing some of the mental health needs of our children. And then we're working on putting our mental health strategy together for the city. And I know what I'm capable of. I know what I'm good at. I know I'm not. That's not something that I'm going to be in a position to do. But very soon we'll be able to announce someone that most of you will recognize, that we're bringing in as an expert to really help lead this mental health strategy for our city. So we'll be excited to announce that. A couple other initiatives. I'll just talk about one more, and then we'll make some time for questions. If you think about the groups that oftentimes are identified as the groups that communities want to pour resources into, right? It's oftentimes children. It's oftentimes folks with mental health issues. Rarely is it our aging population. And the mayor sat down with me and said, "Hey, we need to prioritize taking care of the folks that are aging in Tulsa and find out how we can make Tulsa a more senior-friendly city." And so one of our major priorities is going to be taking care of many of the folks that I am happy to see here in this room, because the aging population is just growing, right? It's growing, and there are relative shortage of resources and opportunities for aging Tulsans. And so one thing we've already done is convene service providers to figure out where are the critical needs for our aging Tulsans. Some things have come up in terms of, providing care when sick or dying, transportation issues, loneliness issues, something that a lot of aging Tulsans are struggling with. And so we are going to really dig into this. We're going to do research, probably in partnership with the OU School of Community Medicine, to get out and survey service providers, our senior Tulsans, family members, to figure out what are the needs. And then from there, figure out what we can do as the city to leverage dollars and partnerships to meet those needs. Right. And so I'm excited about that. So actually I can say when we get our surveys in hand, I would love to kind of get a lot of you all's insights on what you think some of the needs of aging Tulsans may be. And so, and then with that, we will do some initiatives on cancer and chronic diseases. Like, we'll do all the stuff that you've all heard of before that we need, because we do have some pretty significant poor outcomes in cancer and cardiovascular disease here in the city. That stuff will come as well, but we've got to get upstream and get to folks before they get sick, right? The lack of Tylenol does not cause a headache, sort of thing, right? So with that, I will just open it up for any questions or comments. We got hands shooting up, and
Wait.
all right, Mark's gonna mic you up.
I'm appreciative of the fact that you've identified higher education, advanced education as concerns in this city. I'm most concerned about getting people the opportunity to move into higher education.
Yeah.
I think our secondary situation, our elementary situation can be deplorable in a city this size.
Yeah.
And so I'm hoping that you're also looking back as well as looking forward in terms of educational areas.
Yeah, absolutely. The mayor stood up the Office of Children, Youth, and Families, and within that, something called the Children's Cabinet, which is tackling just that, right? That early childhood through high school pipeline, to make sure that we are doing everything that we can to put our students in a place where they can go to college and be successful. It was just announced that we've got a new head of education at the state level that a lot of people are really excited about. All right. Yeah. I feel the same way.
When you talked about bringing the people together, like St. John's and St. Francis and Hillcrest, you did not, I don't believe, mention the VA. To what extent are they involved, if any?
Yeah, that's really great. We've had some conversations with them, but that is something that we haven't talked about enough. And because of that comment, I'll make sure that we have some representation from the VA. My dad's a veteran. He gets his health care at the VA. So that is a really, really good point. I'll make sure that we have some representation from there. Thank you for that.
I have two questions. Or things to mention. Number one is as it relates to the children and having stable homes, et cetera, and a chance for education. I would want to highlight what George Kaiser has done with the CAP program and children that are living below the poverty level. And his program has really done everything financially, et cetera, to introduce pre-K throughout the United States.
Yeah.
And those programs we are thrilled to have in Tulsa. That I think we have to highlight that.
Yeah.
That's a good one. And then number two, the role that GT Bynum is playing at St. Francis. And GT's been here a couple times and visited with us, and his loving aunt is sitting right there. So we have family here at the church related to GT. But my question is his new role at St. Francis as a coordinator. You can highlight that better than I can. The value of that, and is there any intention from the other two major hospitals, or do they have someone in that role? And if not, wouldn't that be helpful as it relates to coordinating healthcare with the community and with the state, and et cetera?
Yeah, great comments. You know, the sweet spot, the passion for GKFF is in early childhood, George Kaiser Family Foundation, and they have CAP, which I think falls under the birth through 8 strategy, which is recognizing that the things we do between birth and 8 years of old for children are what make the biggest impact on their success going forward. And so countless programs that they are leading that are making, I think, really important strides. And we've partnered with them in this work. And so look forward to that. I've met with Mayor Bynum 3 times now since I've been in this role. He's going to play a major role in just kind of helping to bridge our health systems to the Capitol in terms of advocating, because what's going to happen to our hospitals and health systems as the big, beautiful bill kicks in, it's going to be traumatic for them. It's going to create care gaps. It's going to increase the number of uninsured folks, and that's going to take a significant financial burden on all of our healthcare in Tulsa. And so they're working feverishly to figure out how they can kind of make up the difference, and that may have to come from the state level. Not every health system has a mayor that works within them, but they all have access to government relations folks that can kind of serve as a liaison to their representatives and to the state to kind of help advocate for different bills and policy changes. I think St. Francis is in a really good spot with GT being there, and I'm excited to be able to work with him going forward. Yeah. Okay. I think we've got Mark right here. I heard the hand's been up for a little while.
Thank you. Touched on this just a little bit, but to what degree, if any, are the our legislators, both national and local, as well as insurance companies, involved, interested, supportive of these efforts? Yeah.
I sat down with Josiah Sutton, who was the interim president CEO at Community Care. Is now the formal full-time CEO at Community Care. The mayor and I sat down with him at our office, told him about our vision, and he literally said, "We will write you a check today." His support for this work, he was in the picture that I showed. I want to show his face. His support has been amazing. Not only did he say, "We're going to write you a check today," he literally immediately got on his phone and started emailing other insurance company CEOs and saying, "Hey, we're in for $210,000 to support this project. How much are you in for?" So he has been a huge advocate, and I'm really excited to have his partnership because they touch a lot of lives. So Community Care has been a big part. What was the other group that you asked about? Yeah, legislatures. We just had a town hall that had 6 or 7 state representatives attend to talk about these mental health cuts. That was on Tuesday. We met with Representative Mark Lawson. He's out of Sapulpa to talk about those mental health cuts. Right now, that's our focus. And so the mayor he served in legislature for 8 years, which means he has friends and colleagues on both sides of the aisle. And that's really coming in handy to really rally support and some momentum. And they're going to have to be a big part. We would love a special session to look at funding. If we don't get that, we just got to figure out where the money's going to come from, because we cannot lose some of these programs.
First of all, thank you for tackling this big job that concerns all of us in this community. Are the tribes involved at all with the funding and support and collaboration?
Yeah, absolutely. And, as you saw, one of the 6 priorities for the mayor was tribal relations, which they've done really well. I've had number 6 here, great conversations with Muskogee Nation and Cherokee Nation as well. I think we're going to partner with Cherokee Nation on a lung cancer screening across the city with a mobile CT scan and do a lot of things. Things happen about as slow as they do at the city with tribes, so it takes time. But I feel pretty comfortable from the feedback that Cherokee Nation is going to be a big supporter, both financially and through partnerships for this work. And so that's going to be exciting as well. Really good question.
Is there any effort being put forth to address medical debt and how that affects people's situation? The fact is, all the major providers that you're meeting with charge more money for procedures that are not covered by insurance than they do if it is covered by insurance.
Yeah, that's a really good question. I've had some conversations with a couple of individuals who were involved in the pricing transparency legislation. Think about it. Like if you went to a restaurant and there was no prices on the menu and they didn't give you the price until after you ate the food, would that be okay? Right? That's how healthcare is. But the state has a law now where we have some price transparency. We have to get everyone compliant in that, but that's a start, because if people can look online and see how much it's going to cost for a colonoscopy, then they may be more likely to go somewhere else where they can see that it's a little bit more affordable. We're hoping that will help kind of bring pricing down. It's tough right now because the margins are going to get even thinner with the changing in funding and legislation. But that is an absolute real problem. Healthcare is completely unaffordable. And that's a problem with not only the healthcare providers, but also the insurers. And so there's a lot of work to be done there. I think we're out of time. So
that's great. Thank you so very much. Appreciate you. All right. Thank you.